And you're good to go. Hi, everybody. How are you? Can you hear me okay? Give me a thumbs up if you can hear me. Naomi, I can see you hear me? Okay, good.
Okay, I'm here. Are we supposed to have ours on mute?
You can. So basically, we'll just have most everybody on mute. I just want to make sure you guys can hear me okay, because it seemed like there was like a lag in my internet.
Yeah.
If there's any problem with the audio, please just like signal. Most everybody, I would prefer like if they can ask a question in the chat, and then I can answer that pretty easily at that point. So welcome everybody. Thank you very much. I appreciate your help. I'm Dr. Misty and I'm new here at CDA Healing Arts. I work with Dr. Hunter, Dr. Mia, and Dr. Karen here. So my talk that I'm going to just kind of share with you guys today is about SIBO or SIBO, which is small intestinal bacterial overgrowth. And if we get time, we'll go into intestinal methanogen overgrowth. So that's some of the things that I work with quite a bit. In general, SIBO, as I like to just be able to like call it really quick, is a result of having had overgrowth happen in the small intestine. And that can happen for a variety of reasons. A lot of times people come to me because they've had a diagnosis of IBS, and that's irritable bowel syndrome, but don't have any cure or treatment that they know that's going to work besides low FODMAP, which you guys have heard of that piece, but it's just a diet that seems to help with symptom management. And then as far as IBS, about 60 to 80% of IBS is actually due to SIBO. So this is newer research that they realize is the cause of IBS for some people, which is nice to know because otherwise IBS was, there wasn't a solution or a cause known. So when we look at risk factors, like if somebody comes to me with gas and bloating, constipation or diarrhea alternating, people can even have other symptoms similar to like mental fog, brain fog, joint pain, things like that can be other symptoms that people can have. I'm just going to switch my speaker. Okay. And then from there, we look at risk factors that might be causes for SIBO to occur. Hypothyroid or hyperthyroid symptom conditions can cause this because it slows or overly speeds up the intestinal tract. Head injuries is a huge piece. I always ask people if they've had head injuries or concussions in the past, and it doesn't mean you have to be knocked out. Part of the people, a lot of times people think, oh, I never had a concussion, I never got knocked out. But any kind of head trauma can cause damage to the vagus nerve, which is attached to all the way down to heart, lungs, and all the GI tract. It's a bidirectional nerve. So any kind of damage that might be impacting that can actually result in SIBO. And so there's a lot of different aspects as far as risk factors. The two most common factors are, it's considered post-IBS, which is actually traveler's diarrhea or food poisoning. So if somebody's had food poisoning in their history, in which I've seen people with multiple episodes of, sometimes that can result in SIBO also because it can impact the nervous system of the GI tract. And so those are two other additional factors for that. Antibiotic use, significant antibiotic use in history, not just like recent to onset or known onset, but if somebody's had 5 to 10 rounds in childhood or up to their early 20s, that can actually alter the microbiome enough and the interaction of the microbiome to actually create disturbance where overgrowth can actually occur over time. And I think somebody has, actually, I want to say, okay. Other pieces that might come into play would be NSAID use, which is ibuprofen, Aleve, aspirin, common anti-inflammatory that are used. extensive use of that actually can disrupt the mucosal layer of the GI tract. So anywhere from, mouth all the way down through stomach and small intestine, it disrupts the mucosal area, which is actually our immune response where enzymes reside. So when that layer is disrupted, a lot of other aspects besides just the idea of that layer being disrupted occur. So we may not have enough enzymes on board to help break down proteins and carbs and fats in our digestive tract. Allow more than what we normally would allow versus like feeding ourselves some of that food. So those are two other aspects that can happen. Let's see, let me pull up. Other aspects that can actually lend to that also is PPI use, so proton pump inhibitors, which is often used with reflux, and a lot of times with basically any other disruption in the gastric region, a lot of times gets prescribed to people. They will actually reduce hydrochloric acid production, which reduces the ability for us to break down proteins, and also actually to separate vitamins from our meat. So it causes a little bit of disruption in that aspect, which again causes disruption tract eventually. Abdominal pelvic surgery is another one, causing adhesions, which can actually do the GI tract is, very physical. We have a couple different motions that happen in our GI tract. And if we have surgery, that's actually open surgery, we have adhesions that form that actually keep that motion from being fluid and actually allowing fluid to progress through well, but also this brushing, cleaning wave, which is called the migrating motor complex, or MMC for short, gets disrupted also. So when the migrating motor complex gets disrupted, we don't sweep out extra bacteria or debris down towards the rectum. We actually let it sit there, and then that's where overgrowth can also occur. So adhesions can cause that to happen. Similarly, when somebody has endometriosis, anywhere from uterine area to GI tract, which obviously close together, endometriosis can cause adhesion. Autoimmune diseases can put you at a higher risk for a variety of different reasons. Celiac disease is one, which is already not actually, see if you're not gluten-free, if you're not actually taking care of that, then you actually can already have a disruption, because that is also creating other similar disruptions in the nervous system function of the GI tract. It creates a disruption in the immune barrier and the mucosal barrier. So that puts you at a predisposition for that. Other autoimmune diseases like scleroderma, rheumatoid arthritis, connective tissue disorders, those all can do a similar disruption, because our GI tract won't be moving as well, either because of lack of nervous system function that's allowing that and pushing that to happen, or because the connective tissue isn't functioning well enough to actually make that happen. We talked a little bit like the thyroid. If we have hyper or hypothyroid often causes constipation, so slowed GI tract motility. The more or longer somebody has constipation occurring, the less that excess bacteria and debris is moving outward towards the rectum like it should be. So that cleaning wave is not happening as well. And bacteria from the large intestine can actually start moving up into the small intestine because of this. So that's where some of the high stress and anxiety, that's a huge one. A lot of people don't like to admit that they have anxiety or stress that could impact their digestion. We need to be in a resting state to be able to actually digest food. So if you've heard of the parasympathetic versus sympathetic nervous system, if we are in state, which means we're like fight or flight, we're nervous, we're anxious, we're talking the whole time when we're eating, or we're trying to eat on the run like we often do, our nervous system and our GI tract does not actually act accordingly. So our enzymes don't get blood flow is actually not aimed towards the gut like it should be. It's aimed towards all the other muscular functions in our brain to deal with what's going on. So in that aspect, if we have anxiety or higher stress, we are more likely to have and so sometimes treatment for some people or adjust diet. Sometimes it's actually adjusting our lifestyle and our thought process, especially around food and our time we're eating. If we have grown up in a household where dinners are not comfortable, or if we're being reprimanded constantly, a lot of times those things can carry over into our dinner time setting and our food setting now, which means we're not in a parasympathetic relaxed state, we're in a sympathetic state still. So even looking at things as close as that for lifestyle really matter. Alcohol is another one. So if somebody's had current or previous extensive alcohol use, alcohol is directly neurotoxic, meaning that it impacts the nervous system function. So digestive tract, movement of the digestive tract relies on nervous system function. Alcohol also breaks down that same mucosal barrier that NSAIDs or ibuprofen type medications do. So you're impacting a couple of different aspects of the digestive tract that are really important for good function. So if we have alcohol on board or have had extensive use of it, then that can actually impact and cause SIBO also. Pancreatic insufficiency is another aspect, sometimes resulting from SIBO, but more so if we have pancreatic insufficiency, that can happen with H. pylori overgrowth or SIBO or a celiac disease. Certain medications can cause that. If we have low pancreatic function, that means we don't have enzymes, pancreatic enzymes on board enough to actually help digest food. When we're not digesting food fully, we're more than what we're feeding ourselves because we can't absorb it. And it also causes an inflammatory reaction at that point. And similarly, low bile or gallbladder removal in your history can put you at stores bile, which actually helps to digest fats. So in a similar manner, we're what we can digest and what we're feeding other things in our system, we're actually also impacting like the nervous system function again with that, because that has an interaction with a lot of different hormones in our body. Past medical history and other family history, I always look at to see if there's similar things on board in family structures. Sometimes we actually are finding that some things are passed down, not necessarily like orally, like because I have it, you have it, like an infectious disease, but more along the lines because of how we tend to eat, how we tend to have stress or anxiety, some of the things we eat, and then also sometimes because of flora that might be passed down or not passed down from mom to baby. There is some research right now on the other version of SIBO, which is called intestinal methanogen overgrowth. That's actually happening more commonly in families. It's being found more commonly in families the more tests do. So then that at that point, we're looking at why is that happening? And it's so far the thought process that I've explored is it's due to the foods, the functioning of how the family unit and the eating dynamics occur. And I think vaginal flora also for how our immune system is set up, and which our immune is in our gut, 80% of that. So those at this point are like some of the majority of the pieces that we look for SIBO. I have a few of you here now. So does anybody have questions? If you have questions, you can go ahead like forward and giving some more information. Yeah, all good so far? Okay, all right, thank you. So some of the symptoms I kind of went over, but I know some people joined a little bit later. basically symptoms can be ranging anywhere from constipation, diarrhea, or belching, like fatigue. To it. So if you have those kind of symptoms or you're being just diagnosed with IBS, then there might be another reason why, and another thing that we can look at as to what we can do about that instead of just, hey, avoid these foods, or, you know. The thing that's helpful for actually taking things that actually help with symptom management, but that's what's on board. So the way we find out if it's SIBO versus something else, actually doing a test, it's called a breath test. That's the most useful version of the test. There's a couple different variations of the test, but typically it's a breath test, and how it works is that when we are digesting food or fiber or sugar gets down to the bacteria or the organisms in our GI tract, they also digest that food and more pieces left over. And what they digest, they actually also emit gases. And gases would be the ones we look for on these tests. Another one from a different test that we have access to is hydrogen sulfide. So technical realm, there are 3 gases we look for. So again, hydrogen, methane, and hydrogen sulfide. When there's an excess amount so something on, sorry, it passes over into the capillaries or the bloodstream, which actually goes through the lungs and actually off gases through the lungs. So we breathe that out eventually. There's a limited or more portion that we actually will pass through. It's elevated, will come through and we breathe it out. That is how we're testing for this, for SIBO. Is by doing a breath test. We actually literally blow into tubes for this. Hi, Jen. Thanks for the input. I will actually see if I can adjust where I have my network going through. Are you guys having a hard time hearing me sometimes? Is it breaking up? Okay, let me see if I can adjust something to help with that. Okay. Considered lactulose substrate. So we have different substrates, which are sugars that we would ingest for this test. And the options often are fructose, glucose, or lactulose. Lactulose is the best version because we don't actually digest that. Only the organisms in our gut can digest that. So we never absorb it. We only absorb the gases that they create from digesting it. And it actually goes through our whole intestinal tract. So we get from, stomach all the way down to rectum evaluation through this test with lactulose because we never absorb it. So it continues to go through the whole intestinal tract. If it was glucose, that's something that we can actually absorb. So we only get like stomach to like the first few inches of the small intestine because glucose starts to be absorbed at that point. So if we have SIBO or intestinal methanogen overgrowth in this portion of our digestive tract, we're missing that from that test. So anytime I have people get a test, I say get the lactulose test because then we get the whole digestive tract. And then prior to doing testing, it's always important to do a prep. It's just a prep diet's really basic diet that we end up doing that actually keeps from feeding that overgrowth at that point. So that first morning that we're doing this 3-hour test, it's a long test. We have had no feeding of those organisms, so we can get a good baseline to get started with. Like that baseline breath is going to hopefully have very little of any of the gases that we're measuring. And then from that point, we're going to drink that substrate and then do the test every 20 or 15 or 20 minutes, breathing into a new tube to actually see where in our system those levels might get elevated. It gives us a gauge of where SIBO might be occurring and then how far along the digestive tract. It gives me the range of how severe the overgrowth might be, if it's there at all. So when the test comes back, then I'm able to determine from that, like how many rounds of treatment somebody might need, what kind of treatment somebody might need. Each of them have different treatments that I usually focus with. So that's why I usually try to get something that actually either has both 2 of the gases or 3 if possible. As far as treatment options, if SIBO is on board or intestinal methane overgrowth is on board, we can treat with herbals. Often I will do herbal treatment for a lot of people. Another option is antibiotics, which they always think like, well, we might have had this because of antibiotics. A sign that people have SIBO is actually if they feel better when they've been on an antibiotic round. All my digestive stuff went away for like 2 or 3 weeks and then it came back. And that's a good sign that SIBO might be on board because certain antibiotics really help eradicate SIBO. Antibiotics work as well as herbals. I have benefit from both with people. Some people just tend to do better with one versus the other. And sometimes that just depends on their previous exposures or what kind of overgrowth they have or what their general microbiome looks like. So sometimes it's trial and error or whatever fits best in that person's lifestyle, because antibiotic treatments can be 2 weeks long for a round, whereas an herbal round is considered 4 weeks. So it's a much longer time frame for treatment. Herbal rounds also tend to have a lot more pills per day versus antibiotics. So there's a few different things to put in place. With either of those treatments, I always want to make sure we're supporting gut microbiome. We're supporting like die-off symptoms. So if somebody has die-off, just like when you're sick or when you're treating anything else, we tend to get what's considered die-off symptoms from toxins being released from bacteria and organisms. And so I usually do binders and things like that to help with that. And even just, supportive measures like castor oil packs on the belly or laying on the belly to help release gas. There's a lot of different things that people can do to help reduce those symptoms to make it more manageable. Everybody is individual, so I adjust as needed for each person and what's going on in their system. Basically, after treatment, I always gauge, like I said, from one test to the other, like how long a treatment might need. So for each round of either herbals or antibiotics, parts per million, which is how the level of gases that are read in on this test, parts per million, we usually drop about 30 parts per million for a round. And that just depends on how somebody responds, how well they respond to treatment, but that's the average. So if somebody has 60 parts per million showing up on their test, they're going to need 2 rounds. It's kind of the gauge that we think about. Gives us an idea, at least. So after treatment, I look at how is a person feeling? Do they feel 90 or 95% better? Or are they still feeling like, I haven't really made a ton of progress and we still have 2 more rounds to go or 1 more round to go. So then either we will retest to see, are you making progress with this form of treatment or not? Or we move forward with 1 more round to see, like, is there symptomatic improvement? So those are different pieces that we can assess at that point when we get to that stage. And then as far as differentiation between what is hydrogen sulfide SIBO, what's hydrogen SIBO, and what is intestinal methanogen overgrowth. Hydrogen SIBO is the one we knew about most and first. And that one's one that typical symptoms are more like looser stools, a lot of gas and bloating. If somebody has more of a constipation picture, if it's caused by SIBO, it's usually more constipation and it's methane overgrowth. Methanogen producers are not actually bacteria. They're called archaea. Those are the organisms in the gut that actually produce that. And methane they have found actually directly causes constipation because it directly paralyzes the GI tract from wherever it's getting overexposed. And so those are the pieces for those two. As far as symptom like management or symptom matching, I guess I should say. Hydrogen sulfide SIBO is a little different. We just actually had access to a new test this last year that can actually help to test for that. We didn't have a test before for that. We just guessed based on symptoms and like, whether people were actually making progress or not with treatment. And now we have a test, which is great that we can actually see whether somebody has this on board. Because I really don't like treating without, I don't like treating blind. I don't like not, just guessing what I'm treating. Because I think we can do a little more harm at that point. So hydrogen sulfide kind of presents in a variety of ways. We can actually have, it's frequently thought that we have more diarrhea, but we're finding that a lot of our patients do have constipation with this. More often people will feel more toxic or ill. So severe brain fog, body fatigue, brain fatigue, joint pain, just generally not feeling well, feeling like they're sick, like with a virus basically the whole time. And the cause of that is because when we have hydrogen or methane in our system, certain levels, a higher amount of those levels seem to be okay. But when we have hydrogen sulfide on board, we're supposed to, our body can handle a certain amount of hydrogen sulfide, which is normal and natural. Any elevation above a small amount starts to cause symptoms pretty quickly. And a lot of them are neurologic type symptoms also. So numbness and tingling, feeling like ants crawling on your body sometimes, things like that can happen for some people. And like I said, all of those have a little bit variety of different types of treatment that we can do. And if somebody tells you like, you only have IBS, go home, take Gas-X, here's a diet, low FODMAP, just go ahead and restrict your diet for the rest of your life. I would say, check it out. Either come into us or ask your gastro or whoever for a SIBO test, because more and more doctors are becoming familiar with it. Not everybody is highly familiar, which, you can't expect them to know everything, but even I don't know everything about this, obviously. So just kind of asking and pushing for what you need for your care is really important. Those tests are pretty readily available at this point. So if they can actually do it and you can get the information, if you need help and support with treatment, reach out to people that are actually trained in it, either here or somewhere else. There's quite a few other people out there now that actually have a lot more training with SIBO and experience with it. So any questions right now? And you can unmute yourself if you want to. It's usually, we only have a few people, so it's otherwise you can put it in the chat field if you actually have questions that you need.
Is there anything else that we can do at home to try to minimize symptoms? I know following a low FODMAP helps, but that does get pretty old. And is there anything else we can do?
At home, yeah. So low FODMAP is symptom management, like you're saying. So a lot of pieces for symptom management have to do with sometimes we have binders on board that actually help with toxins and pieces like that that might be coming out, because a lot of times if we have methane overgrowth, if we actually are able to bind that methane up, that actually helps reduce the impact that it has. Like I said earlier, methane directly causes nerve paralysis of the GI tract. So being able to bind that up and get that moved out is really helpful. Keeping stool moving is always really helpful. And then just general, like a lot of times, as far as like abdominal pain and pieces like that, sometimes, like I said, the castor oil packs and things like that can be really helpful for reducing inflammatory response and actually, allowing some soothing to go on. I can't give a lot of direct information because I'm my patient directly. So there are things, and some of it's just limited to like, it is symptom management. A lot of times low FODMAP helps a lot of people. My concern is that long-term low FODMAP is not a healthy diet. And so there's been a lot of discussion, like with our groups, with my peers and I, and internally inside myself trying to figure out how to best treat. Like, do we treat? Because like even, you know, when you're killing stuff off, you're killing more than just those specific bacteria off. Can we just do diet? Can we do probiotics? You know, all those pieces. We haven't found a lot of success with just using diet or probiotics kind of aspect, or prebiotics even. So unfortunately, like most of my successes has been with people that are, I've used antibiotics or antimicrobials, and then rebuilding gut and expanding diet. Because the expansion of diet is really important at some point, because you still want to make sure that that family, that microbiome, that neighborhood in your gut is really important to have a huge diversity. And when those bad actors is like what we like to call them, when they overgrow, they create a whole new environment around them that impacts that whole neighborhood. So it's kind of like the bad seed in the neighborhood drawing in more bad seed. So if we can treat that and then, you know, heal the gut and then actually re-expand the diet to actually allow feeding of like the whole neighborhood, that's the best way to do that. I don't know.
Does the archaea actually go hide sometimes?
Do they hide?
Hide from treatment?
So any of those organisms can actually hide in them, and it's called a biofilm.
Mm.
So they can hide in biofilm. Oh, I'll answer your question just 1 second, Jen. They do. So anytime, like when we have mucus in our sinuses, or we have, sometimes people will pass mucus in their stools and stuff like that. It's usually an inflammatory type of thing. But at the same time, organisms throughout our gut and yeast, everything creates this biofilm around themselves that actually protects them from, you know, hydrochloric acid from us, that actually helps break things down, from our immune system that can target it. It protects them from other organisms nearby, and it actually protects them from the antibiotics or the antimicrobials. So yeah, they can hide. And so sometimes we put biofilm disruptors on board also that actually help open that up, so that when we're doing treatment, it allows antibiotics or antimicrobials to get in there and target that a little more directly. Yeah.
Thank you.
You're welcome. Yeah. Jen, you asked what the diet I'm referring to. So it's FODMAP, it's low FODMAP, and it's FODMAPS. And it's just a diet that's used for IBS. It was developed by a university out of Australia for IBS before we knew what SIBO was. And it actually helps reduce symptoms of gas, bloating, sometimes the constipation, diarrhea, but it actually helps manage symptoms with IBS a lot of times. And it also helps with SIBO because it's similar, obviously. If you have more questions than that, please let me know. You can always look it up online pretty readily, and there's apps on people's phones that you can download for low FODMAP diet. Yeah. Anybody else have questions? So far, so good. Okay. That's the majority of what we do with it and what it is. Like I said, I encourage everybody, if you've been diagnosed or if somebody in your family's been diagnosed with IBS and not given any support or any thoughts about what to do, do seek that out or look into it a little bit. You're more than welcome, obviously, to come here and check out with me. I do say that IBS is usually a diagnosis of exclusion, meaning that your doctor's already gone through every other test they need to check to make sure that nothing else is wrong. I don't see that being done quite as much anymore, unfortunately. We're actually making sure all the other pieces are covered, but I will usually go through and make sure you don't have celiac disease, you don't have other like autoimmune diseases, you don't have just a simple H. pylori overgrowth. There's a lot of different things to look at to make sure before we start treating other things. Like, but I do test for SIBO pretty frequently. So yeah. That's kind of all I have right now for that. There's a lot to it. And I know hopefully it was understood. I think that'll be posted on our webpage later. And so you can kind of review that and look at that again if needed. And if you have more questions, you're welcome to reach out to the clinic and reach out to me. So yeah.
Great.
Thank you. I hope you guys have a great day.
Okay, thank you. Bye now.
Bye.